I'm Dave Duplay. I'm here with Richard Marais. Richard is an expert in cancer research. And Richard, I know that a lot is going on in immunotherapy these days. What are you working on, and what should patients know?
Hi, Dave. So my lab is primarily interested in the problem of melanoma. It's a form of skin cancer, and you can cure most patients. So actually 80% of patients are cured by surgeons who remove the tumor. But that means that 20% of patients obviously have the metastatic, that means the spreading form of the disease. And for those patients, the new therapies are targeted therapies, and they're very exciting new data about immunotherapies. Now, the targeted therapies work by attacking the cancer cells, whereas the immunotherapies work by waking up the immune system, and then the immune system, so your own body, goes out and finds those cancer cells and kills them.
And so what determines the treatment path for those patients looking at both targeted and immunotherapies? How is that treatment path determined?
Of course, this is a very complex discussion between the patient and the clinician, but largely speaking, if the patient has a specific type of mutation in a protein called BRAF, and that would be about 50% of melanoma patients, they are eligible for the targeted therapies. Now, if they don't have that mutation, then there are very few alternatives, and so largely speaking, for the patients who don't have the BRAF mutation, it would be immunotherapy. For the patients who do have the BRAF mutation, the BRAF damage, it will then depend on the extent of their disease, where they are in the patient journey as to which therapy, and that's really a discussion for them and their clinician. It has to be said that the immunotherapies can actually cure patients. So I would imagine, largely speaking, most patients would elect to have the immunotherapy even if they have the BRAF mutation.
And Richard, what do you see on the horizon? What do you see in the next, let's say, 5 to 7 years in cancer research? What's going on in the lab today that we should be aware of and we can look forward to in the future?
I guess there are two different types of consideration there. The first is the very basic early discoveries that are teaching us new things about the biology of cancers, but these are a long way from the clinic. You know, these will be many, many years. 5 to 7 years is probably about the right length of time. I think what's more exciting and more immediate for the patients is the idea of combining these different types of treatments. So how do you combine in an efficient and effective way the targeted therapies with the immunotherapies? As I mentioned, only 50% of patients will benefit from the targeted therapies. Not all patients will benefit from the immunotherapies. And so what we're doing now is we're trying to learn how to combine those in an effective and intelligent way for the individual patient. And so we will personalize the treatment for each patient and treat that patient, not the whole herd of patients. And by that mechanism, we will get much, much better effects and cures in patients.
Well, Richard, on behalf of our patient community, I want to thank you for stopping by. Keep up the great work, and we look forward to seeing you again soon.
Okay.
Thank you.